So this lecture is entitled Dental Radiology, a Primer on Reporting, and it's meant to serve as a guide for general and neuroradiologists. Much of what is discussed in this lecture does not need to be mentioned in most reports, but in cases where a discussion of dental disease is warranted, I think accuracy and clear language is really important. So in this talk, I'll briefly review the relevant dental anatomy. I'll discuss the two main disease processes that affect the teeth and supporting structures. I'll discuss the classic sort of hallmark imaging appearance of each disease, and I'll give recommendations for sentences that can be included in your reports. And then finally, I'll summarize key findings or key points in this lecture. In adult humans, a full dental complement comprises 32 teeth housed in two bilaterally symmetric arches. In each quadrant, half an arch. Beginning in the midline, humans have two incisors, central and lateral, one canine, two premolars, first and second, and three molars, first, second, and third. The primary dentition differs slightly from the adult in that there are no premolars and only two molars. Several different dental notation systems exist, and not all dental professionals use the same system. These can be confusing, and my recommendation is to not use them. Instead, I recommend referring to teeth using the following paradigm: side, arch, maxillary or mandibular, and tooth. For example, right maxillary lateral incisor. If uncertain, such as in the case of multiple missing teeth, a specific description should be given. For example, the right most posterior mandibular molar. The terms used to describe the location of structures within the oral cavity also can be confusing. The terms medial and lateral have the same meaning as in other contexts, towards and away from the midline. The term mesial, however, as opposed to medial, also means towards the midline, but is restricted to locations on the dental arch. Conversely, the term distal describes structures which are further from the midline of the dental arch. For example, further away from the central incisors. Not only can individual teeth be referred to as mesial or distal within the arch, but on any given tooth there is a mesial aspect and a distal aspect, for example, of this first molar. This diagram of normal anatomy is crucial to understanding what is to come in this lecture, as the way in which dental disease alters normal anatomy is the basis for the image findings you see on panoramic radiographs and CT. Dental anatomy can be divided into the tooth itself, the dental tissues, and the supporting structures called the periodontal tissues. The mature tooth is composed of enamel, dentin, and pulp. The tooth can be divided into two segments, crown and root. The crown contains all three types of tissues, whereas the root contains only dentin and pulp. The outer enamel layer of the crown is 96% inorganic and entirely acellular. Within the crown, just underneath the enamel, lies the less mineralized dentin. This layer is also acellular, but contains cellular processes from the dentin-producing odontoblasts, which reside in the periphery of the underlying pulp. The pulpal tissue contains blood vessels, connective tissues, and lymph tissue, and nociceptive fibers, and has a coronal component called the pulp chamber, as well as a root component called the pulp canal. The tip of the root, where nerves and blood vessels enter the pulp, is termed the apex. The tissue surrounding the tooth, termed the periodontium, consists of cementum, periodontal ligament, alveolar bone, and the gingiva. Cementum is the thin cellular layer surrounding the root, which allows attachment of the periodontal ligament fibers. The periodontal ligament is a thin 200 micron layer tissue that extends from the alveolar bone to the cementum. Alveolar bone houses and supports the teeth within the maxilla and the mandible. The thin cortex of the alveolar bone facing the periodontal ligament is termed the lamina dura and is an important radiological landmark. Finally, The gingiva is the soft tissue covering of the alveolar bone and forms an important tooth-mucosal junction. The panoramic radiograph is commonly ordered in the hospital setting, and therefore a basic understanding of the maxillofacial anatomy on this study is helpful. This diagram is fairly self-explanatory. One point I would like to make is that of the appearance of gutta percha, a common root canal filling material that can be seen as a linear or curvilinear radiopacity within the root system. Shown here is a cropped image of a panoramic radiograph demonstrating normal dental and periodontal structures. Note the radio-opaque amalgam filling material in the crown of the right mandibular second molar. There is no evidence of decay on this image. There's no coronal radiolucency, and the enamel dentin junctions are intact. Also, the alveolar bone is at the appropriate level 1 to 2 millimeters below the crown root junction. Shown here is a dedicated periapical dental radiograph. One point I want to make is the far superior quality of this radiograph compared to the panoramic radiograph when evaluating for dental disease. The dental and periodontal structures are well visualized here. The thin periodontal ligament can be traced around the roots of the teeth. Notice the rounded radiolucency below the second premolar. Also note the adjacent periodontal ligament space and lamina dura are completely intact. Therefore, this radiolucency represents a normal structure and not apical pathology. This structure is the mental foramen. Okay, so here is a very important slide. I'm going to take you through the etiology and pathophysiology of the two main types of dental diseases, and that is decay and periodontal disease. So first I'll start with decay. One thing I want to say is that colloquial terms like rotting teeth or decay are used, but this is a true infection just like any other infection, like a staph infection in the skin. There's a specific bacteria that causes decay. It's Strep mutans. And so you really need to look at this as an infection. It is transmissible from person to person and is, again, an infection. So it starts with a little bit of plaque and bacteria build up on the surface of the teeth, and consumption of carbohydrates will get converted to acid by the bacteria and cause demineralization of the tooth. If the tooth then collapses, it'll form a cavity. But again, in this stage where it's only affecting the enamel, it's completely asymptomatic. There are no nerve fibers or processes that project into the enamel. When the demineralization and the decay process extends into the dentin, this is often symptomatic because I think, as I mentioned before, there are cellular processes that extend into the dentin with these cell bodies that lie inside the pulp chamber. And these cellular canals can convey changes in osmotic pressure and temperature and can be sensed by nerve fibers within the pulp. When the decay is affecting the dentin, typically patients have cold sensitivity, but what's interesting is they can't identify the exact tooth, and that's because there are no proprioceptive fibers within the pulp. Eventually, the pulp will become involved as well. Let me switch this to black so you can see it. And this will cause a pulpitis. Again, this is also symptomatic, typically as it affects more of the pulp. At some point it'll be irreversible, and you get warmth sensitivity and what's called lingering sensitivity. A radiologist is not going to be able to diagnose pulpitis because the pulp is already lucent. So you can note the lucency in the crown and the enamel and dentin, but you really can't detect lucency within the pulp. Eventually, the infection will make its way out the root apex, and it'll cause inflammatory changes in the periodontal tissues around the apex. And this is also very painful, but in contrast to the pulpal pain, this pain can be localized to a specific tooth, and that's because the periodontal ligament is filled with proprioceptive fibers. And that's essentially decay. The inflammation around the apex will cause a reaction, typically resulting in resorption of bone, but occasionally resulting in sclerosis. The resorption of bone can be from an abscess, it can be from what's called a granuloma, which is really just a granulation tissue, and an epithelial line cyst from embryologic dental remnants can form in this region as well in response to the inflammation. So a periapical radiolucency is actually nonspecific, and it can be an abscess, cyst, or granuloma. You can argue whether or not it makes a difference because it all occurs in response to decay. All right, so that is decay. Next, I want to take you through periodontal disease. So periodontal disease, again, it's a true infection, just like any other. It's caused by a different group of bacteria than dental decay, and I'll take you through the pathophysiology. So this starts with buildup of plaque and bacteria in the subgingival space, specifically in what's called the gingival sulcus, which is right there. And as the bacteria proliferate, it causes irritation and inflammation of the gingiva and causes gingival hypertrophy. This deepens the gingival sulcus and makes it even more difficult to clean. And these bacteria again proliferate. The specific group of bacteria, mainly gram-negative rods, produce an endotoxin called LPS that causes a robust inflammatory reaction in the periodontal tissues. And this typically results in bone resorption. And the bone loss typically at the beginning is what's called vertical bone loss. And it leaves this vertical strut of bone that kind of props up the soft tissues and maintains an even deeper gingival sulcus, which again is difficult to clean and bacteria proliferate, and it's kind of a positive feedback cycle. It's interesting that actually one of the treatments of periodontal disease, in addition to a deep cleaning, is to chop off that piece of bone so that you have a nice rounded horizontal bone defect, and that allows the gum tissues to recede back down to, let's say, this level, and will shorten the depth of the new sulcus, making it cleansable. You've lost bone support, but at least you have a cleansable situation. And that's essentially periodontal disease. Obviously, this can be mild, and you can just have a little bit of bone loss. It can be moderate if it's in the middle of the root, and if it's in the apical third of the root, and the bone loss is all the way down here, then that's termed severe. So that's pretty much it. In summary, and this will help later with imaging, in decay, the bone loss is in the periapical region, and in periodontal disease, the bone loss is in the alveolar crest. Okay, so now I will preview the imaging findings that are characteristic of decay. Decay starts radiographically with a lucency in the coronal tooth structure, and when that decay makes its way through the pulp and out of the root apex, you can see widening of the periodontal ligament space, loss of the lamina dura, and a periapical radiolucency. In some cases, and I'll show you an example of this, you can get periapical sclerosis. If the infection goes through the cortex, it can also cause a subperiosteal abscess, which you're really only going to be able to see on CT. So I included this panoramic radiograph because I think it's funny that the text left the glasses on, but this radiograph also demonstrates areas of coronal decay involving the left maxillary second premolar, as well as the distal aspect of the left maxillary first molar. There are multiple areas of decayed, missing, and restored teeth, and that actually could be a good simple summary of this image. Multiple decayed, comma, missing, comma, restored teeth, period. So case 2 actually I don't think demonstrates any active decay, but it does demonstrate amalgam fillings quite nicely, and it also demonstrates what a root canal looks like on panoramic radiograph. There's root canal treatment of the roots of the right mandibular first molar. Also shows the appearance of a nose ring on panoramic radiograph. This panoramic radiograph demonstrates multiple decayed, restored, and missing teeth. In particular, there's a decayed root tip in the left upper quadrant. There is also coronal radiolucency representing decay of the maxillary left third molar. This radiograph also demonstrates the artifact you typically see or often see in the midline, and this is partially due to superimposition of the cervical spine. Root tips can be sneaky. There are decayed right mandibular first molar root tips that were not called on this radiograph. Here is a patient with multiple decayed teeth. Note the loss of coronal tooth structure and periapical radiolucencies. Here's another example of decay on CT. Again, note the large amount of coronal tooth structure loss, as well as the periapical radiolucencies. On the left is shown an axial section CT through the maxillary arch. There are radiolucencies surrounding the apices of the right maxillary premolars, also shown in the coronal plane. Same patient, same images, here in soft tissue windows. Notice the hypodense subperiosteal collection representing an abscess. Here are coronal and axial CT sections demonstrating widening of the periodontal ligament space and periapical lucency involving the right mandibular first premolar. Note the overlying soft tissue swelling. Same patient on soft tissue windows demonstrating a small subperiosteal fluid collection, also representing an abscess. So in the setting of decay, a subperiosteal fluid collection is an abscess, no matter the size. Unlike elsewhere in the body, do not say no drainable fluid collection is present, even if the collection is really small. Why is this important? Because in the mind of an ER doc, an abscess equals drainage, and no abscess equals antibiotics. But antibiotics are never sufficient for treatment of a tooth infection. To a dentist, all decay involving the pulp or periapical tissues require drainage of some sort, either via a root canal or extraction. When multiple periapical radiolucencies are associated with sinus opacification, consider odontogenic sinusitis. Note the near complete opacification of the right maxillary sinus with air fluid levels. Also note that the maxillary infundibulum and ostium are patent. So when is a periapical radiolucency not decay? There is this condition called periapical cementosseous dysplasia, and I don't want to go into it too much because it's beyond the scope of this lecture, but it's in the category of the benign fibroosseous lesions. It's more common in middle-aged black females, and it involves radiolucencies around the periapical regions, which in the early stage are radiolucent on X-ray, and in the late stages fill in with central opacity or central sclerosis. This clinically can be distinguished from decay in that the teeth will be vital, they will not be necrotic, and so clinically it really shouldn't be confused with decay, but radiographically it can be. The dedicated periapical radiograph on the left demonstrates periapical radiolucencies, and then to the right of that there's a periapical dental radiograph taken later on in the disease course, and you can see within the periapical radiolucencies there are areas of radiopacity. The panoramic radiograph shows symmetric periapical radiolucencies in the mandible, representing an early stage of this disease. I don't think you need to mention it in the differential most of the time, especially in the radiolucent phase, but when you see the radiolucency with the area of sclerosis within it, I think that is more specific, and in that case you should mention this entity in your differential diagnosis. So here's another example of when a periapical radiolucency may not represent decay. Remember before I said that a periapical radiolucency could be an abscess, a cyst, or a granuloma, and that all of these result from decay. And so it kind of begs the question, does it matter if it's an abscess, cyst, or granuloma? And there is a case where it does, and that's because a cyst may remain even after treatment of the tooth. So you can treat the decay with extraction or a root canal, and the cyst would remain, whereas an abscess would likely go away. So if you see a periapical radiolucency on a tooth with a root canal, it may not be decay, and it may represent a residual radicular cyst. So I just want to take a second here to mention something about the panoramic radiographs that are ordered prior to cardiac transplantation. A panoramic radiograph alone is not standard of care for preoperative dental evaluation, and official guidelines recommend evaluation by a dentist in addition to radiographs. So you can pretty much include in all of these reports, if you want to, the following statement that says, dedicated dental radiographs and evaluation by a dental specialist is recommended. Okay, so some helpful sentences for describing decay. If you see a radiolucency in the coronal tooth structure, it's decay. To summarize a lot of these reports, since really the treatment is the same, you can say there are multiple decayed, missing, and restored teeth. And that can be it. That can be most of the report. If you want to get more specific, you can say there is decay involving the left maxillary central incisor, for example. But again, I don't think you always have to be that specific. If you see a periapical radiolucency, it's probably worth mentioning, although it is just another sign of decay. But you could say there is a periapical radiolucency associated with the mandibular right first molar or first premolar, for example, compatible with abscess, cyst, or granuloma. And remember, you really can't tell, but it all indicates decay. You can word it like this. There is a periapical radiolucency associated with the right maxillary lateral incisor. In the setting of percussion sensitivity, this is most compatible with a periapical abscess. Finally, if you see a periapical radiolucency with a subperiosteal collection and overlying soft tissue stranding, that's an abscess, and you should call it as such. So an example would be there is decay involving the right mandibular first molar with adjacent subperiosteal abscess and overlying cellulitis. The imaging appearance of periodontal disease is quite simple. There's either a horizontal bone loss or a vertical bony defect, and that's pretty much it. You can describe the severity of the bone loss as mild, moderate, or severe, depending on whether the bone loss from the crest extends inferiorly to the coronal third, the middle third, or the apical third, respectively. Here's our friend again. In addition to the decay mentioned earlier, there is generalized horizontal bone loss around multiple teeth. So you've seen this radiograph before in the section on decay, but this panoramic radiograph also demonstrates generalized horizontal bone loss compatible with past or present periodontal disease. Case 3 nicely demonstrates vertical bony defects on sagittal section CT compatible with periodontal disease. Note this pattern of bone loss at the alveolar crest and contrasted with the periapical bone loss surrounding the roots of the decayed mandibular first molar. Cases 4 and 5 again demonstrate horizontal bone loss on sagittal section CT compatible with past or present periodontal disease. This slide demonstrates a special case of periodontal tissue loss. In this sagittal section of a maxillofacial CT, there is a horizontally impacted mandibular third molar, causing a vertical bony defect of the distal aspect of the second molar. This situation is highly unhygienic and active periodontal disease is likely present. In cases of severe disease, it can be difficult to tell if the bone loss is caused by periodontal disease or decay. Severe disease can have a nonspecific appearance, with both periapical and alveolar crest bone loss. Lucency in the crown of the tooth and lack of periodontal disease elsewhere would suggest decay. So here are some helpful sentences you can include in your report. If you see horizontal bone loss, you can say, there's generalized, moderate, for example, horizontal bone loss compatible with past or present periodontal disease. If you see a vertical bony defect, you pretty much know there's active disease. And you could say something like this. There is a vertical bony defect along the mesial aspect of the left mandibular canine compatible with periodontal disease. Okay, we wouldn't be radiologists if we didn't know how to hedge, so here are some helpful hedges. The anterior teeth on panoramic radiographs, as I mentioned, are difficult to visualize. So you can say the anterior dentition is poorly visualized due to superimposition of the cervical spine. Dental evaluation is recommended. Also on panoramic radiographs, you may not be sure if there's a periapical radiolucency. And so you can say questionable periapical radiolucency involving tooth X. Correlation with exam by dental specialists is recommended. And we talked about cases where there's extensive bone loss around the periapical region and the alveolar crest, and you're not sure if it's decay or periodontal disease. And in these instances, you can say there is significant alveolar bone loss around tooth Y involving the alveolar crest and periapical region. This pattern of bone loss can occur from severe periodontal disease or decay. And the next statement is optional, and it depends if these findings are present, but you can say, given the lucency involving the associated coronal tooth structure and the lack of periodontal disease elsewhere, this is felt to represent decay. So here are the key points for the lecture. When it comes to naming teeth, it's important to be concise and specific, and I'd say forget the numbering system. Lucency in the tooth structure or in the periapical region is a hallmark of decay. Subperiosteal fluid collection associated with the decayed tooth is an abscess, so you should call it as such. Don't forget about root tips because they can be difficult to see. And don't forget about odontogenic sinusitis. In contrast to the periapical bone loss seen in decay, alveolar crestal bone loss is synonymous with periodontal disease. When the bone loss pattern is nonspecific, you can look for coronal radiolucency to suggest decay or periodontal disease elsewhere, which may suggest a periodontal etiology.